Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in the NICU. I was preparing this Teach Me Tuesday with my typical 10 Instagram slides, a great short 15 to 20 minute intensive on YouTube, and I realized I had a lot more to say. So as a special Nurses Week, NICU Nurses Week surprise, there's going to be a two-part for this week. We're going to do half of the anomalies today and half of them on Thursday. I then struggled to decide if I should do it all in one YouTube video and ultimately decided to do two. So here we are with part one. Now, I'm sure you're thinking to yourself, wow, she must really cover like all of them in that two-part series. Absolutely not. That's just impossible. There's too many. But I'm going to cover the ones that we see frequently, maybe things that you've had questions about, and to reinforce that some of them have talked about before. On Thursday, we're going to briefly cover congenital heart disease, but we have gone over that extensively in February, so you can go back and check that out. But without further ado, let's talk about a few things. So when you think about congenital anomalies, you really should think about these things that happen during fetal development. So something like HIE is happening at birth. Something where you have a brachial plexus injury is happening at birth. And yes, it could cause some issues with the baby's limbs. HIE can cause issues with the baby's body. IVH, right? That happens after birth and of course can cause a lot of issues, including but not limited to cerebral palsy, learning differences, etc. But what we're talking about is today is things that happen during that fetal development, usually in the first trimester, maybe the second trimester, where something that genetic code just isn't laid exactly the same as another baby. So we also are at a place now where we are calling these more, birth defects or differences, congenital differences in babies, because there shouldn't be a negative connotation to these. It's just what makes that baby unique. So today we're going to talk about a lot of things with craniofacial and limbs and kind of go from there. So let's get started. The trisomies will be on Thursday. So TE fistula, right, that's a craniofacial in a way, right? We're talking about something at the upper part here. I kind of wanted to start with like upper body. I don't know why. Don't ask me my weirdness. But this is where the trachea and the esophagus are abnormally connected. I like to think about this as something that, yes, is congenital. Often we don't know about it before the baby is born. And when we do, it's because usually it's the most severe kind and the baby will have polyhydramnios or an absent stomach bubble, meaning that they have polyhydramnios because they aren't swallowing and they have an absent stomach bubble because there's no air getting in there because there's no connection in their esophagus. So esophageal atresia and TE fistula are going to go together. But typically for this baby, we're going to see extrauterine, a lot of bubbles coming out of their mouth, unable to feed the feeding tube. So this is an x-ray of exactly that, where the feeding tube goes down and curls back up. They have this big round belly because they don't have that connection. They can't get those two things together. When they're feeding, they may turn bluish, cyanotic, because they cannot effectively exchange their oxygen. And then again, we cannot feed them properly. So these are the 5 kinds. Type A is when it's esophageal atresia. The trachea is not really involved, but that esophageal atresia is very common to see intrauterine because of the polyhydramnios. Type B is there is this atresia, but you have a fistula. So now your esophagus is attached to the trachea. And you can understand how dangerous that would be if we started feeding the baby and where the food would go. Type C, now that doesn't feel as nerve-wracking for if we feed them because this is when the bottom half, the distal fistula, is coming off of the trachea. And that means a lot of air is going to go into the belly, almost like this air leak over to the belly. Type D is when you have a complete double fistula, which also just seems wild to me. It attaches and then also it's like a tunnel is going through there. And then type E is when there's the fistula connected directly to the trachea. Now, of course, all of these are dangerous and the baby will have breathing difficulties. And if we cannot feed them, obviously we have issues with that and we wouldn't want to start feeding them and then have them at risk for obviously aspirating milk into their lungs. So they do need immediate surgical intervention. Most babies are going to be placed NPO and be given some sort of sump pump or Rapolgal, something that's going to pull the fluid out so we don't risk them aspirating any of that fluid into their lungs. Often these Rapogel tubes are going to be placed by a surgeon, and so they should never be replaced by bedside staff unless instructed to. So look at your policy for what you should be doing with surgically placed Rapogel tubes. And then they will reconnect them, and often the babies will do well after surgery. Sometimes they have some difficulty with feeding and some difficulties with reflux, so that's something that you would want to be paying attention to. Some more craniofacial differences would be our cleft lip and palate. So in cleft lip, it's when the tissue doesn't fully form at the top, and then the cleft palate is the roof of the mouth. A baby can have a unilateral cleft lip, a bilateral cleft lip, and they can have it with and without the cleft palate. So a lot of different things can be going on here. The cleft lip is more common to notice during pregnancy. You can see that on antenatal ultrasound. In the last, I don't know, even since I started my career, but definitely in the last 10, 15 years, they treat these very differently than they did when I was a child 30, 40 years ago. Before, there was a lot of surgery right away. Now, babies often will go home with their cleft lip, and they have specialty feeding or specialty ways of doing breastfeeding, specific bottles that they can use. But there's been a lot of advances in the care of these babies and what we can do for them and helping kind of prevent long-term repetitive surgeries. So the surgical repair is usually performed in stages. The cleft lip will go in the first few months of life. Again, not like we're doing it right before they leave the hospital. The cleft palate repair can be up until they're 18 months old, and these babies are going to have a lot of long-term care with speech therapy and dental care. Choanal atresia. I always like to talk about this one when you can't pass that feeding tube and you're asking yourself, like, is it me? Can I not pass the feeding tube? Is it because I can't do it? And then you try the other side. But this, bilateral is way more obvious than unilateral, because those bilateral babies, because babies are obligate nose breathers, all of a sudden they cannot breathe and they're having cyanotic issues, increased work of breathing, etc. And you're like, oh my God, like what's going on here? Then you try to pass the tube and you're like, okay, something more is going on here. They will end up getting scoped and getting some surgical. You'll see these pictures where they like try and putting almost like straws up to stent it open, but ultimately if there's a complete blockage such as this picture, the baby would need surgery. Unilateral isn't as diagnosed as quickly because the baby could still be breathing and eating well, but may have more of an issue when they are eating, because all of a sudden they're only able to breathe with one side, not their mouth, and they're trying to suck, swallow, and breathe, and it just doesn't go well. So just thinking about kind of, how much is it and how would it affect the baby? So Pierre-Robin or Pierre-Robin sequence, you've probably heard about in our old friend NRP. This is one of our favorite things to teach in NRP, especially if we're going to talk about needing a LMA, a laryngeal mask airway. So these babies are born with this kind of severe recessed jaw, and they will have a hard time getting PPV because you can't get that seal on there and their jaw is in the way. So that's micrognathia. I always have a difficult time saying that, so you are not alone if you have a difficult time as well. So that's a smaller than normal lower jaw. This can obstruct the airway. They usually have respiratory distress issues and feeding difficulties. We will do mandibular extractions, where they're trying to pull that out. You can see it with a little screw on the side. I've seen one with a button. I had never seen this surgery until I started working at my last facility, because at the place I primarily spent the first 13 years of my career, we did not do these kinds of surgeries. Those babies were shipped to a children's hospital. So I did not see these surgeries for a long time. So if you've never seen that, you're not alone. Rest assured, you're still doing the right thing in the right place. But if you do go to a delivery for a baby like this, you would think of how can we best help them with their difficult airway. So they may need to be placed on their stomach or their side. When they are on their back, it really causes that jaw to recess back further. So thinking about that during your resuscitation, maybe you have to use an LMA to help them breathe, is just something to think about. As they get older, depending on when they're going to have their surgery, if they've had their surgery, they may also present with feeding difficulties. So something to think about as the baby is aging. Limb differences, so limb anomalies can be present at birth due to a variety of things. These are just pictures of some examples. I did not go through and get every single one. I thought that this list would be the most helpful to kind of understand the differences of what's happening here. You will see this. We do talk about this in NRP as well too. We talk about what happens if a baby is born without a right hand. Because why do we need to know about a baby's right hand? Remember, during and after delivery, not during delivery, immediately after delivery in the first few steps of NRP, we place the pulse oximeter on the right wrist. If a baby doesn't have a right wrist, we talk about what would you do next, and that would be the left wrist, which would be your next choice. There are places that might have ear SpO2 monitors, but those are very rare, so more than likely you're going to end up using that left hand instead to get your pre-ductal saturations. But I'll let you read through these. These are all the kind of different ones that we have here. Clubfoot might be something you see more frequently than others. I would say clubfoot and polydactyl are probably the ones I see the most, in addition to having, a amelia or a partial where there's an axial limb defect, primarily from amniotic banding. But those are the ones I've probably seen the most in my career as far as kind of the limb differences. So primarily these can come from a chromosomal anatomy such as trisomy 13 or 18, which we will dive into on Thursday. It can be part of VACTERL. So VACTERL is vertebral anomalies, anal atresia, cardiac defects, TE fistula, renal abnormalities, and limb defects. So VACTERL is a set of, when they see all those together, they actually start going and looking for the others. So maybe you have a limb difference and a TE fistula. They're going to start looking for renal anomalies, anal anomalies, and any cardiac defect. So they kind of all go together. And then amniotic banding is when there's amniotic fluid that has banded around a limb, almost like you've left a rubber band on too long or something, and it can lead to limb differences. You can see those in different places on babies' bodies, but primarily we as NICU nurses are going to see it on an arm or a leg, somewhere like that. So as I mentioned, we're going to have a part 2 on Thursday. I broke this up just to kind of have enough time to talk about each thing. But really, we want to remember is how important of a role we play in the management of these. Sometimes we are going to be the ones that catch these anomalies, whether that's being unable to pass a feeding tube in something such as conal atresia, whether it's unable to ventilate properly because of a recessed jaw, or noticing polydactyl on your first assessment, right? That first initial assessment, you're head to toe. Maybe you do a more thorough one if you have an AHR, electronic health record such as EPIC, where you're doing that full initial assessment in there and you're going through each part of the body piece by piece. You're going to be noticing these things. A TE fistula, maybe you're noticing all that frothiness at the mouth. So your initial assessment and ongoing assessments are going to be key drivers to identifying some of these and kind of what the next steps will be. So check back on Thursday. We will do a couple more anomalies. We're going to go more in depth on parent education. I know I touched on it on the last screen with limb differences. Primarily wanted to mention it on the limb differences screen just to think about what a parent might be reacting when their infant is born with a limb difference. So join me on Thursday. I will be back for a few more congenital anomalies and a little bit more on parent education. Have a great Tuesday.